Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. Tonight's presentation is titled Common Foot and Ankle Pathology with IHA Orthopaedic's Foot and Ankle Surgery. Our presenting provider is Trinity Health Medical Group Orthopedic Surgeon Neil Bakshi. He sees patients at Schoolcraft Campus in Livonia as well as in the Genoma practice in Brighton. Welcome, Dr. Bakshi.
All right, thank you guys all very much for having me. I know it's hard to get time away from family on a Wednesday evening, so I appreciate it, and hopefully this will be worth your time. Feel free to ask any questions in the chat, as Allison mentioned, and happy to answer really anytime. So we'll go ahead and get started. This is going to be an abbreviated list of kind of common foot and ankle pathology, but if you have questions about other pathology, feel free to, like I said, ask in the chat. I'm going to go through kind of the most common things that come through my clinic, and we'll kind of go from there. Really the most common thing that comes into my clinic is kind of a classic acute low ankle sprain. This is kind of your classic inversion ankle injury from either playing a sport or walking on uneven ground, and you twist your ankle. This is typically an inversion injury, like I said, where the outside side of your foot basically gets stretched out, and the ligaments on the outside of the ankle, the ATFL and the CFL primarily, they get either partially torn or completely torn. This is really more than 90% of ankle sprains. Typically, people will present with swelling and bruising, as well as decreased range of motion and pain on the outside aspect of their ankle, typically right where that prominence is, which is called the lateral malleolus. For an acute low ankle sprain, typically what we do is we ask patients to rest and immobilize their ankle in a boot for about 2 to 4 weeks, apply ice and use over-the-counter anti-inflammatories like Motrin or ibuprofen. Following that initial period of rest and immobilization, we typically transition patients from a boot over to an ASO brace, or an ankle stabilizing orthosis. And then typically we'll get patients started in some sort of physical therapy, whether that's a regimen where they go 2 or 3 times a week for 6 weeks, or maybe just go once to learn the home exercise program and do it at home. Really, we focus in on trying to initially gain patients' range of motion back in all different planes, followed by initiating straight line activities. What I mean by that is typically jogging, running, biking, maybe an elliptical, basically anything that doesn't involve cutting and pivoting. Those lateral motions are the toughest on a lateral ankle sprain like this. And so cutting, pivoting, and sport-specific activities are typically saved for once you've advanced through these initial 3 phases. Now, every so often, these acute ankle sprains can turn into more of a chronic picture. In that situation, we typically use, like I said, the ASO brace, or the ankle stabilizing brace, and initiate that full regimen of physical therapy 2 or 3 times a week for 6 weeks. And typically what this physical therapy is aimed at is strengthening what's called the peroneal tendon. So those are the tendons that sit on the outside of the ankle, just behind the fibula bone. And typically what we do, when the ligaments on the outside of the ankle aren't working, we can sometimes train the tendons on the outside of the ankle to really substitute in and take their place. And what we do is we try to train those tendons to be able to fire and to activate before you turn your ankle. And in order to do that, what that typically requires is a lot of balance and strengthening exercises. So what that entails is, potentially walking on a balance beam, or if you go to the gym and, sitting or utilizing one of those Bosu balls or exercise balls, and really working on strengthening those tendons as much as possible. During this time period, though, patients need to, and providers need to, watch out for mechanical symptoms, including catching and locking within the ankle joint. So if there is catching or locking in the ankle where a patient has difficulty with doing range of motion of the ankle and it feels like their ankle is stuck, some patients will describe it as it feels like there's a pebble in their ankle. There's a concern for a loose body within the ankle, or there can be concern for a cartilage lesion or a defect that happened during an ankle sprain event. If anything like that presents itself, that's definitely a red flag and something that we should be contacted about. So if we do the initial phase and we do the physical therapy and the bracing and the pain still is not improved and we continue to have instability events or ankle sprains, then we move on to a small surgery. And what that entails is a small incision on the outside of the ankle. And then we place 2 suture anchors into the tip of the distal fibula. Those suture anchors basically look like drywall anchors with sutures or stitches that come out from that. And then we utilize those sutures or stitches to repair those outside ligaments in the ankle capsule in a tighter position than what it was before to better stabilize the outside of that ankle. As we mentioned earlier, the peroneal tendons work as a stabilizer on the outside of the ankle when those ligaments are no longer working properly. And so oftentimes those tendons tend to get inflamed or angry because they're essentially working overtime. So during this procedure, what we'll do is before we fix those ligaments back down to bone, I'll take a look at those tendons and clean up any inflammation and look for any tears or degenerative changes and fix those while we're there to be able to repair any tears at the same time. So following this lateral ligament repair is called a Brostrom repair. So typically what we'll do is we'll make patients non-weight bearing for anywhere to 2 to 6 weeks is the recommended regimen. I typically split the difference and do 4 weeks of no weight on it. We do get you from a splint to a boot at the 2-week mark and have patients start doing range of motion. And then around 4 weeks, we'll let you start walking on it. And at 6 weeks, we initiate physical therapy. This initially starts with just simple range of motion exercises and gradually moves on to strengthening. And then by the 10 to 12 week mark, we'll get patients into more sport specific activities. But typically this is a 3-month recovery and patients are able to return to sports around 3.5 months after surgery. So if ankle sprains are the most common thing that comes through my clinic. Plantar fasciitis is right there with it, or is probably second. So plantar fasciitis typically presents with pain on the plantar or the bottom side of the foot, right at the heel. Where you're looking is basically right at the heel where basically it says plantar fascia, right at the base of it is where most patients will typically present with pain, but it can often radiate into the arch. It's typically painful with the first few steps of the day. The main source of plantar fasciitis, the main cause of this is a really tight calf muscle. So tightness of the gastrocnemius and the soleus muscles, which are the 2 primary muscles that make up the calf. And this is often typically associated with a flat foot deformity. So what do we do for plantar fasciitis? So I mentioned that having a really tight calf is the primary reason for this. So what we typically do is ask patients to stretch their calf as much as possible. So I typically start patients with a consistent home exercise program, asking them to do these stretches that are shown on the bottom right, 2 to 3 times a day, every day. If needed, we can also start patients in a physical therapy protocol as well. If those stretches don't seem to be doing it, then what we'll do next is initiate a dorsiflexion night splint. So basically a splint that stretches out the calf for 6, 7, 8 hours overnight, and basically functions as some physical therapy overnight for you. One of the big things I wanted to put in this presentation is to make sure you don't get any injections for plantar fasciitis. The issue with the injections, they can make you feel better for a short period of time, but the issue with them is that they can leak into the fat pad that sits just underneath the plantar fascia. And when it does, it can kill that fat pad. And when that fat pad is lost, you can't get it back. And then essentially your heel is just sitting pretty much on the ground. It's equivalent to sleeping on a wooden pillow as opposed to a nice cushioned soft pillow. There's no way to be able to fix that problem down the line. So if we do the stretching and the physical therapy and the night splint and can't get the plantar fasciitis to decrease in pain and symptoms, then the last resort is really moving on to a surgery. And as we mentioned earlier, the primary reason for plantar fasciitis is a tight calf muscle. So what this surgery really does is it lengthens the calf muscle. And what we do is typically the incision I make is, if you look at that picture on the top right, I make an incision just above that purple line and use a retractor to basically show the white fascia that sits on the calf muscle. And I just gently take a knife and graze along that fascia to lengthen out the calf muscle just a little bit. And this is effective about 95% of the time when treating plantar fasciitis. Moving on, we'll move on to Achilles tendon pathology. So the Achilles tendon is basically it's the tendon that combines the plantaris muscle, the gastrocnemius, and the soleus muscles, and it attaches them down to the heel bone or the calcaneus. It's the strongest and the thickest tendon in the entire body, and it's about 15 centimeters in length. The tendon can receive a load stress of about 4 times body weight during walking and can receive a load stress of 7.7 times body weight during running. The middle section of the Achilles tendon is much more hypovascular, meaning it has a much worse blood supply than the top part of the tendon or the bottom part of the tendon. And that's part of the reason why that 95% of Achilles tendon ruptures and a lot of different Achilles tendon pathology tends to occur in that area. The areas that have much better blood supply tend to be able to heal and not have as big of issues and complications like an Achilles tendon rupture. So this is just kind of a vascular map of the Achilles tendon. If you look at the pictures on the left and the right, you can see that there's much more blood supply at the very top as well as at the very bottom of the Achilles tendon compared to the central area in the green on the right. That area, the bottom area of green, basically shows that that's kind of the central area that really doesn't have a lot of blood supply to it. So Achilles tendinopathy is one of the most common things that comes in. This typically occurs in middle-aged patients or kind of our classic weekend warriors. Studies show a prevalence of about 10 to 15% in recreational athletes and moderately active athletes. This is in comparison to our professional athletes who have a prevalence of Achilles tendonitis or tendinopathy of less than 5%. And really the majority of those athletes are really 35 and older. The reason why Achilles tendonitis or tendinopathy occurs is due to repetitive microtrauma or repetitive very small injuries and overuse in the setting of a really tight calf muscle. You need both of them to basically end up with Achilles tendonitis or tendinopathy. 2/3 of Achilles tendinopathy is the non-insertional type. I got some slides coming up that'll better demonstrate that. And then the insertional type, the one where it occurs at the heel, typically occurs about 1/3 of the time. Again, this is the same root cause as plantar fasciitis. And actually a lot of patients and people do come in saying that they've had plantar fasciitis in the past. So patients with Achilles tendinopathy typically present with pain directly over the Achilles tendon, either at its insertion on the heel bone or at the mid-substance, just higher up on the Achilles. They typically present with swelling, burning, and stiffness. You'll notice in the insertional type, so the type where they have tendonitis at the heel, progressive bony enlargement right at the heel. For the non-insertional type, patients will present with a enlargement or a bump higher up on the Achilles tendon. Patients typically present with pain with increased activities, particularly with running, jumping, and stairs. They'll often describe morning stiffness as well as thickening of the Achilles tendon at the site of pain. So on physical exam, You'll notice swelling and, excuse me, sorry. You'll notice swelling and enlargement at the site of the tendinopathy, whether if it's insertional Achilles tendonitis, it'll be primarily at the heel, which you can see in the bottom picture. If it's non-insertional type, you'll see it like you do in that top right picture, where the prominence and the enlargement is higher than at the heel. There'll be pain with palpation or with pressure on the Achilles tendon, as well as just medial and lateral, just to the sides of the Achilles tendon. And then patients will typically present with a really tight calf muscle. The tightness in the calf muscle typically leads to excess tension or pull on the Achilles tendon that really is the root cause of this issue. On imaging, the insertional Achilles tendonitis presentation. So on X-rays, you'll typically see something called a Haglund's deformity. So if you look, Allison, can they see my my mouse?
Yes, they can.
Okay, perfect. So if you look at my cursor over here, this area right here, this is called a Haglund's deformity that I'm circling here. That is an excess of bone or bony prominence that forms at the top of the heel. And this is very classic for insertional Achilles tendonitis. The second thing that really points to insertional Achilles tendonitis as the diagnosis is something called an enthesophyte. So if you look here, this is basically here as well as this lower part here. This basically occurs because of that repetitive microtrauma and overuse causes the insertion of the Achilles tendon, so the tendon to actually start turning into a bone-like substance. So this demonstrates really nicely the location of the insertional Achilles, basically the footprint of where it inserts. And in this situation, it starts to turn into basically bone. On MRI, you can see thickening and degenerative changes of the tendon. You'll notice that Haglund's deformity as well, that prominence of bone. And then you'll notice a lot of inflammation in the adjacent bursa, or kind of the fat pad adjacent to it. For non-insertional Achilles tendonitis, you'll typically see a normal appearing X-ray. You may see increased soft tissue shadowing in the area of the Achilles tendon, but for the most part, it's a pretty normal X-ray. Where you do notice changes are one on the physical exam, as we said, and then on the MRI, you'll notice thickening and edema or swelling of the tendon just proximal or just above its insertion. So on this picture on the bottom right, you can see where this black line coming right here is the Achilles tendon inserting onto the bone right here. And about an inch or two above it, you can see this area where the Achilles tendon is not like the rest of it. It's starting to become degenerative. That white signal is indicating fatty degeneration of the tendon and prominence at the site. So treatment for Achilles tendonitis, whether it's insertional or non-insertional, again, I want to point out the importance of not getting injections for this. This increases the risk of a rupture. One thing that a lot of patients mention to me in clinic is they're very worried about an Achilles tendonitis turning into a rupture. And that's an extremely uncommon thing to happen, actually, other than in this one situation where a patient gets an injection at this site. But it's extremely uncommon for a non-injected Achilles tendonitis to turn into an acute tendon rupture. So typically, if a patient presents with an acute exacerbation or flare of Achilles tendonitis, I'll typically want to calm it down at first. So calm it down with a boot and heel wedges just to take pressure off the Achilles. And then really do the same things that we would do for an ankle sprain. Rest it, ice, modify your activities, and anti-inflammatories. If patients present after the acute flare is over, or if they didn't have an acute flare, typically what we'll do is we'll initiate physical therapy. That physical therapy is aimed at eccentric strengthening exercises. And what that is basically what we see in the top left picture here. So typically start with on a step with the feet in a plantar flex or a downward position. and then you slowly lower your heel towards the ground. And what this does is it strengthens the Achilles tendon, it strengthens the calf muscle while you're elongating the muscle in the tendon. And this has really strong level 1 evidence for treatment of insertional Achilles tendonitis, but we found that it works really well for non-insertional as well. And then really the second thing, as I mentioned for plantar fasciitis, is again, we have a tight calf muscle, so we really have to stretch out the gastroc and the soleus muscles to be able to help take the tension off the Achilles, whether it's at its mid-substance or at its insertion. If we do physical therapy and it just does not seem to be getting better, the next step is to move on to a medication called nitroglycerin. And this medication comes in a patch form. This is a medication that some of you may have already heard of. It's typically used for chest pain for patients with heart problems. And what we found is that there's actually very good level 1 evidence to support its use for the non-insertional Achilles tendonitis. I have found, though, that anecdotally, it seems to work very well for the insertional type of Achilles tendonitis as well. Typically, what we do is we have patients take a patch, cut it into quarters, and place a patch on the painful spot each day. They place it in the morning and take it off before bed at night. It typically takes about 3 months to see a difference compared to the placebo in these studies. But what we found is that 6 months of using this patch can result in maintained pain relief out to 3 years after patch initiation. Why 3 years? It's because that was how long it's been studied so far. So it may last for even longer than 3 years, but we just don't know based on the literature that's been performed already. So, other treatment options include, again, a night splint, like we talked about for plantar fasciitis, as well as something called iontophoresis. So this is something that can be done with physical therapy. If there's any physical therapists, please excuse my explanation of this because it's probably a pretty basic level explanation. But basically what they do is they utilize, I prescribe you a steroid ointment or cream, and a physical therapist will utilize iontophoresis, or they will utilize an electric current to basically help to that steroid penetrate the skin and get down to the level of the Achilles tendonitis to be able to provide the steroid's anti-inflammatory effects locally at the site. So if we do for insertional Achilles tendonitis, if we do the physical therapy and if we do the nitroglycerin patches and the other treatments that we discussed, first of all, if I see 100 patients with that type of a picture, probably only 3 or 4 of them actually end up requiring a surgery. So the odds of getting to a surgery are extremely low for this issue. But if you're in that unlucky 3 or 4% that needs a surgery and just don't get better without it, there is a very good surgical fix. Typically what we do is we make an incision directly over the Achilles tendon. We split the tendon basically down the middle, and we clean up the bone, that Haglund's deformity, or those big spurs that I showed you on the X-ray and the MRI. We use a saw and some other tools to basically clean that up. And then we do a really thorough cleanup of the Achilles tendon as well to make sure there's no degenerative tissue that's left. And then basically what we do is we repair the Achilles tendon back down to bone and repair that split that we made in the Achilles. Now, after we do the Achilles tendon debridement, if we take away a fair amount of the tendon, and everybody's got a different threshold. My threshold is if I take away more than 50% of the tendon because it is too degenerative and it's not healthy enough to leave, then typically what we have to do is a tendon transfer. And I have some pictures of that coming up. So typically what that bony debridement looks like is you can see the Haglund's deformity on the left, and we clean it up with a saw or with some other instruments to be able to get the picture on the right to create a nice smooth border for the Achilles tendon to insert on. And then it also provides really good bleeding, good bone for that Achilles to heal down and to better heal the the Achilles. This is what the Achilles tendon repair typically looks like. We use 4 anchors and create kind of a suspension bridge or a double row repair to be able to fix that Achilles back down to its footprint on the calcaneus. For non-insertional Achilles tendonitis, the surgical treatment is frankly even simpler. And typically what we do is the same thing that we would do for plantar fasciitis. So again, its root cause is the really tight calf muscle. So what we do is a calf lengthening, and I do the surgery at the exact same level that I do for plantar fasciitis. And it has a good 90 to 95% chance of getting people better. The recovery after this particular surgery is far better as well. Typically, you can walk on it right from day one. I ask patients to wear a boot for about 1 week, but we do a waterproof dressing so you can get the incision wet right from day one, and it's overall pretty straightforward. So, as I mentioned earlier, if you have to debride or clean up too much of the tendon because it's unhealthy, you don't want to leave that unhealthy tendon behind because that'll be a pain generator for patients. What you have to do is a tendon transfer. And the tendon that we typically take is the FHL, or the flexor hallucis longus. So there's a few different reasons why this is a good tendon for transferring. One is, so if you look on this MRI picture on the top, the white arrow right here points to the Achilles tendon. This tendon just deep to it is the FHL, or the flexor hallucis longus. So what we can do is go just deep to the Achilles tendon and harvest this flexor tendon. The other reason why this is a good option is there is redundancy to the big toe. So this is one of the 2 tendons that flexes the big toe down, but there are 2 tendons that do that. So we can utilize one of them. It's a very vascular tendon, so it provides a lot of good blood flow for healing. Basically, what we do is we cut the FHL tendon to be as long as possible for grafting, and then we pass the tendon, as you can see on the picture on the bottom right, through the heel bone, and we basically put what's called a biotenodesis screw into the calcaneus, or the heel bone, to basically hold that tendon in place and assist and help heal the Achilles. So the rehab for this, we typically do no weight on it for 6 weeks. This is if you do an insertional repair or the flexor tendon transfer. And then we typically do weight bearing as tolerated from week 6 to 12 with a boot and some heel wedges to take pressure off the Achilles. We typically start patients in physical therapy at the 6-week mark, gradually starting with range of motion, and then eventually moving on to more strengthening exercises, and then eventually getting patients back to the activities that they want to do, whether it's pickleball or other sports. Typically, patients return to sports somewhere between 6 and 12 months, but realistically, it's probably closer to the end of that range, around 9 to 12 months. But I typically clear patients to get back starting at 6 months. So Achilles tendon ruptures, this is the last topic that we're going to talk about. So this is more common in men than women. It's typically, again, in that age range of 30 to 40. Very common in the weekend warrior. Very, very common story for me is we were playing pickup basketball. It was the first time I've played in 5 years, or, we were playing touch football at Thanksgiving, and I haven't played a sport in a long time, but I figured I'd play. And it's typically a non-contact injury. Somebody was trying to change direction quickly, and you push off on the foot, and basically they experience an audible pop. It's not typically associated with Achilles tendonitis unless it's been injected. 90% of the tears occur within the mid-substance, or the middle of the Achilles tendon. As I talked about, that's the area that has the worst vascularity or blood supply. And so that's why tears tend to occur most commonly in that location. So when you present to clinic, typically most patients will present with increased resting dorsiflexion when they're laying on their abdomen. So what that is if you look at the picture on the bottom right, This patient is laying on their abdomen, and the foot that's closer to the screen, their right foot, is the Achilles tendon rupture side. The left foot is the side that's intact, and you can see that the toes on the intact side are pointing towards the ceiling, and the toes on the non-intact or the ruptured side are pointing straight to the wall. And that's a very good indication that this patient has a full thickness Achilles tendon rupture. Typically, you can feel a palpable gap in the Achilles tendon. You can see that on the picture on the bottom left. And then the last thing we really do is we squeeze the calf and see, does the foot fire in a downward direction? If it does, that means that it's either not torn or it's a partial tear. If it doesn't have any motion in the foot, that means that you have a full thickness tear. At some point on this pulley mechanism or the Achilles tendon, there is a full thickness rupture, because firing or grabbing the calf, squeezing the calf, doesn't seem to be, that cord is clearly detached. Typically, there's no imaging that's required for an Achilles tendon rupture, because if all of these exam findings are present, we are 99.99% sure that this patient has an Achilles tendon rupture. So the interesting thing about Achilles tendon ruptures is that they can be treated with or without surgery, as long as patients present to a doctor within the first 2 or 3 days after the injury. There's some level 1 evidence that basically shows equal re-rupture rates whether you do a surgery or not. The literature does say that there's maybe some decreased strength with non-operative management, but for the most part, outcomes are roughly equivalent. What I do and what most physicians do in this area is we feel that non-operative treatment is a perfectly reasonable option if a patient's seen within the first 2 or 3 days after an injury, or if they're splinted or placed into a boot in significant plantar flexion or in a downward position, and they are non-weight bearing. And then it really comes down to a patient and their preference and their activity level on whether they decide to do a surgery or not. I will say that most of my patients, probably under 30 or 35, typically choose to do a surgery. Most of my patients over 50 or 55 typically choose to do non-operative treatment. And then it's kind of a mixed bag in that 35 to 55 range. So this is some of the literature that discusses Achilles tendon ruptures. And this study really found equivalent re-rupture rates with surgery and without surgery. They found similar strength testing in most testing states. The operative leg did do better, slightly better in all of the testing states, and we'll show you that on the next slide. The biggest take home from this paper, though, was early functional rehab, where we let patients start doing some range of motion, is really, really important. So what we used to do in the past was we would put patients into a cast for like 2 months in a plantar flex position. And what we found in that situation was that patients actually did really poorly. So what we started doing now is I typically place patients, if we're doing a non-operative treatment, we typically place patients into a splint or a boot for 2 weeks, and we kind of just let it rest. And then as soon as 2 weeks, we typically have patients start doing a little bit of range of motion. And what we found is that it actually lowers their future re-rupture rate. So this demonstrates, this is just a graph that kind of shows the difference in strength for operative and non-operative treatment. You can see that the operative leg did slightly better in all of the testing states. It was only statistically significant or a significant difference in a couple of the testing states, but it did seem to do a little bit better in all. This is another more recent published paper. This was published in the New England Journal of Medicine. It did find a significantly different re-rupture rate, with operative treatment having a 0.6% re-rupture rate and non-operative treatment having a 6.2% re-rupture rate. So it was significantly higher with the non-operative treatment option, but still relatively low for both groups. If surgery is chosen, this can be done in an open or a minimally invasive fashion. What this paper found was that the rates of nerve injury are significantly higher with the minimally invasive surgery than it is with the open repair. So this kind of just goes through what an open repair versus a percutaneous repair looks like. The open repair is on the left. Typically about a 3 or 4 centimeter incision is made just medial or just to the inside of the Achilles tendon. The reason why is you don't want the scar to be directly over the back of the Achilles. It can irritate patients and irritate with shoe wear and things along those lines. This is a slightly longer incision than that of the minimally invasive technique. So with a longer incision, you're typically going to have a slightly higher rate of wound complications, but it's not significantly higher. But there is a lower rate of a sural nerve or a nerve-related injury. And you can control the tendon length a little bit easier. So I can fix the tendon in a more tight or strong position with the open method. With the minimally invasive technique, the primary benefit is that it's minimally invasive, so it's a smaller incision, meaning you have a lower wound complication rate. But there's a higher rate of hitting the sural nerve, a nerve that sits right near the Achilles tendon, and it's a more expensive construct. Typically, what I do for Achilles tendon ruptures, if we're doing a surgery, is typically about a 4 centimeter incision on the medial side or the inside side of the Achilles. It helps to avoid the nerve, and it avoids a direct incision right on the back of the Achilles. We typically open up the sheath that sits on the Achilles. And then we do a running kind of locking suture that you can see on the right side of the screen that we do on either side of the Achilles tendon. And then we tie it basically in the tightest position possible. And the tightest that we tie the Achilles tendon together, this potential future, the higher that your potential future strength is. So for the rehab associated with an Achilles tendon repair, this is a long rehab process. It's the same whether surgery or not surgery is chosen. The biggest thing is I really don't want you to stretch for this. Strength is the name of the game, and it's the primary reason we do this repair in the first place. Typically, what we do is we keep patients non-weight bearing for about 5 or 6 weeks. We have patients in a splint for the first 2 weeks, and then we switch you to a boot. To allow you to do range of motion, basically starting at the 2-week mark. And then at the 6-week mark, we'll typically start doing weight bearing as tolerated in a boot, and we'll gradually get you out of the heel wedges. And we'll typically start doing physical therapy at the 6-week mark as well, to initially start with just basically learning how to walk again, building up some basic lower extremity muscle, working on some range of motion, and then eventually getting more into strengthening for the calf muscle around 12 weeks. Typically, patients can return to jogging between 3 and 6 months. I will clear them for sports, usually around the 6-month mark. But most patients are typically returning to sports closer to 9 or 12 months. And that's pretty much it. So if anybody has any questions, it looks like we have a decent number in the chat.
Yeah, we definitely do. So if you have a question, you haven't entered it yet, you can do so by typing it into the Q&A feature, which is at the bottom of your Zoom screen again. I didn't mention before, I forgot, you can ask your questions anonymously. If you choose to do that, just make sure you select it before you submit. Okay, so I am going to just get started. There's a question about a toe bone causing reoccurring foot callus. Is there a way to prevent the callus from forming?
Yeah, so calluses, we would have to know exactly kind of which toe bone in particular, but in general, calluses that typically form in the front part of the foot on the bottom side, it's typically coming from overload or irritation. So if this is coming at the level of the toes, then it's typically coming from toes either rubbing against each other, or it's coming from excess pressure or overload on the front part of the foot. And I know I've hit it pretty hard throughout this presentation, but one of the main reasons for developing a callus at the front part of the foot is typically overload and having a very tight calf muscle. The foot is a tripod, and so the way that we typically put weight down on our foot is a lot of weight on the heel as well as weight on the front part of the foot. Now, if the calf is too tight and if the calf is too tight, basically the heel spends less time on the ground and the front part of the foot spends more time on the ground, and meaning that you're overloading the front part of the foot. So doing those same stretches for your calf muscle is likely contributing. It would be beneficial for this. But I would have to probably know better with a true picture or a physical exam.
Okay, if you'd like to add a little more detail, I will try to find it in the questions, if that was your question. Okay, have you heard of toe curling as it relates to Parkinson's disease?
I have not. There's a lot of different reasons for having a hammer toe or a curly toe. I will tell you, neurologic reasons are a big contributor for hammer toes or claw toes developing. So there is a high likelihood that there is an association there because hammer toes and claw toes are associated with a lot of different neurologic conditions like diabetic neuropathy, or there's another condition called Charcot-Marie tooth. And those are very well-known relationships. So I wouldn't be surprised if there was a relationship with Parkinson's.
Okay, I think another maybe neurological condition. How about neuropathy? Do you ever treat that?
We do. I definitely treat neuropathy. If it's related to diabetes, I think the biggest thing is getting good control of your blood glucose. But we definitely treat problems related to the neuropathy and manage the symptoms that can often occur with that.
Okay. And does yoga help strengthen tendons? There's a lot of bam.
Absolutely.
Oh, sorry. Go ahead. You're going to answer.
Yeah, no, absolutely. Yoga can definitely help with strengthening of the tendons. It can help with a lot of the flexibility as well. So I think it's fantastic for basically all of the for the tendons in the foot as well as the flexibility that it provides throughout the calf and the rest of the foot.
Okay. So this person has had left ankle pain for about a month, and they're using an ankle brace or a wrap, which provides support and reduces the pain. It does not seem to get better or worse. Is there something more they should be doing? So they've had a braced ankle for about a month, and it doesn't seem to be improving, but it's also not getting worse.
Yeah, so there's a lot of different reasons for an ankle brace or wrap can benefit a lot of different conditions. So it's a little bit tough to tell. I think we would have to probably see somebody in clinic for that and know exactly what the etiology or the cause of the pain is and why an ankle brace is needed to better evaluate exactly what's going on. What I would say is that if an ankle brace or a wrap is providing benefit, two of the most common things that it could be are ankle instability if a patient's dealing with chronic ankle sprains, or it could be ankle arthritis. And what the brace does is it basically stabilizes the ankle so there's less motion across the arthritic ankle joint. And the less motion you have across an arthritic joint, the better it's going to feel. I think, again, if more that I should be doing, I would have to probably evaluate a little bit better based on x-rays or a physical exam. But if it's helping and it gets better with anti-inflammatories and a brace, I would say keep doing it.
Okay, and there are a lot of questions about arthritis in the ankles. Is a brace like a permanent solution, or is there a time in a brace that will make it possible for you to not be in the brace in the future?
Sorry, Allison, can you repeat that question? I just
Yeah,
going through
so
the.
there are a lot of questions about arthritis in the ankles. So I'm wondering, is a brace a permanent solution for ankle arthritis? Or is there hope that maybe you can live without a brace in the future?
Yeah, it's a great question. Our typical place that we start for ankle arthritis, we typically start with an ankle brace, or the specific type of ankle brace is an Arizona brace. That's what I use in my clinic. And it's kind of a tight lace-up ankle brace that can provide a lot of basically stability across the ankle. And then we typically start with that and anti-inflammatories. Hoka shoes, or any kind of shoes that have more of a rocker bottom, basically where the shoe kind of looks like the bottom of a rocking chair, can provide a lot of benefit. The reason those are good is because they can the shoe propels you forward rather than your ankle having to do the range of motion to propel you forward. So those are all beneficial things. In general, that arthritis is not getting better with non-operative treatment, in the sense that, like, you can make the symptoms better, but the arthritis itself is not changing. So typically, if a brace is helping, I would say that that is better than having a surgery, and it would then become a permanent thing. Now we do ankle steroid injections, so that can be beneficial as well. And so if that sufficiently treats your ankle arthritis, then you may not require a brace, and making a brace not as necessary. And then finally, we do either ankle replacements or we do ankle fusions for ankle arthritis. And typically, most patients with an ankle replacement or an ankle fusion don't require a brace as well.
Okay. All right. So we have someone who has plantar fasciitis. They started PT yesterday, taking naproxen, and they have very flat feet. It looks like they're 65 years old. So they're wondering if the pain will stop. They have been fitted for inserts in the shoes. And then, so I guess the question is, will the pain stop, and should they stay active in things like golf, bike riding, and dancing?
Yeah, so I think that's great that you've already started physical therapy. I think the pain should really get quite a bit better with physical therapy. The key with that is, if you're going once or twice a week to physical therapy, you typically need to be doing those stretches every day, ideally twice a day if possible. And I would totally recommend everybody to continue to be as active as possible. What I tell my patients in clinic is, when you first initiate physical therapy, I'd probably take it easy for the first 2 or 3 weeks. Really do the therapy, but don't go play your typical sports, or don't go, do rigorous running or exercise for the first few weeks. But then once you've really initiated the physical therapy and feel like you've got a good, you're starting to see a little bit of benefit, I definitely recommend patients to get back into their activities. What I've found is that physical therapy typically takes a couple weeks to really start seeing some really good effect.
Okay. We have several questions about high arches. Can you maybe talk a little bit about things you can do before you have issues if you have a high arch?
Yeah, so it's a great question. So, patients with high arches typically, the best thing to do, there is a good orthotic that is available. And typically, I'm not a big custom orthotic person, so I typically tell patients to try over-the-counter orthotics. And there's one called the Foot Scientific Type 3. Allison, is there a place that I can type this in?
Yeah, you could pop it into the chat. I believe they should be able to see the chat, or you can drop it in as a question as well. And then
Okay.
we'll also
There's
include a link to this in the email that we follow up with. So they'll be able to.
Okay, perfect. There's one question that says, do you know what Cava-Varus deformity is, and what is the typical plan? So I'm going to type an answer to that. And so I'll do
Okay,
foot
perfect.
scientific type 3 orthotic. This is the orthotic that I've found that works best for a high arched foot. And it's usually, I typically just bring up the Amazon link to patients in clinic, and it's the one that I use. I really start all of my patients with that. And it seems to work quite well.
Okay, and how about the same question for flat feet? Is there something that can be done before you have an issue to help
Yeah,
you?
so in general, if patients are if they are not having pain, you don't necessarily need to do anything, because most patients with flat feet typically will never go on to have pain. Now, if you wanted to start doing using flat foot orthotics, let me find that question. I'm going to type another answer in here for the cable varus, but I'm going to type flat foot orthotic. It's also available on Amazon. Step.
So for both flat feet or high arches, the answer is like an orthotic or something in your shoe. Is that the best thing you can do?
If it's before people are having issues, there is not much else to do. I think for patients with flat feet, the other thing that you can do that's really important is keeping your calf stretched out. So having a tight calf plays a big role with flat feet. And so using the orthotics and making sure you're stretched out is really beneficial for flat feet. For a high arch foot, I think really the biggest thing is the orthotic.
Okay. And then can you talk about, it looks like foot pain that is worse in the morning, but it improves over the day. Hang on, I'm trying to get back to the question. 1 second, sorry. Okay. So this person has, since age 50, she has a high arch and pain in the bottom of her feet, primarily the pad of the big toe and the sides of the feet. She wears prescription orthotics and does stretches, as well as multiple types of PT, but hasn't had much help. So she has a high arch, pain in the big toe pad, as well as the sides of the feet. Is that something that you've dealt with?
Yeah. Can you describe that one more time?
Yeah, sorry.
No, you're good.
She has, since age 50, she has pain in the big toe pad as well as the sides of her feet, and she has high arches.
Yeah. So actually, that orthotic will work extremely well for you. So patients with a very high arch, basically what happens this is kind of a simplified description, but basically what happens is the head of the first metatarsal, so the bottom of the great toe basically gets dug into the ground. And what you need is an orthotic where there is a recess or kind of a cavity that's created for the head of that metatarsal or the great toe. So there's more space for it in your shoe, and that actually helps to correct the deformity that's there, and that can help the pain at the bottom of your big toe. There's two bones at the bottom of that big toe called sesamoids, and typically patients with higher arches tend to have what's called sesamoiditis or inflammation at that site.
Okay. So you talked a little bit about feeling like you might have a pebble in your foot or the bottom of your foot. So this person says they feel like they have hard balls under their feet, but when they examine it, they can't find any bumps. Any ideas what that could be?
We would probably need a little bit more information on exactly where that is. A lot of times people describe that as they describe a marble at the bottom of their foot in the front part of their foot. And typically what that is metatarsal overload or metatarsalgia. And again, it comes from a couple different things, but one of them is having a tight calf muscle, and the other is either arthritis in the big toe or some sort of a reason why you have overload of the smaller metatarsals. So a lot of those patients will typically present with a callus at the bottom of their foot. And they'll typically describe more pain with walking barefoot than you are walking on shoes. Walking on hardwood is more painful than walking on a nice plush carpet. And so these are, if this is kind of what that condition is, then typically you benefit from the stretching, gastroc and soleus stretching that we talked about. And there's a good orthotic or a good shoe insert that I can give you in clinic called hay pads, or metatarsal pads. And when they're placed appropriately, they can do a good job of helping with the pain, or that feeling of having a marble or a bump at the bottom of the foot.
Okay. Can you talk a little bit about the difference in the symptoms of neuropathy versus plantar fasciitis? How do you know kind of when it's one or the other?
Yeah, it's a great question. So, neuropathy typically starts when it's peripheral neuropathy. It typically starts more in the toes than it does at the bottom of the heel. So, if it's pain at the bottom of the heel, more often than not, that is plantar fasciitis. But peripheral neuropathy typically starts more so in the toes and works its way up.
Okay. Have you ever recommended patients use a wobble board or do air pad exercises, like balancing on one foot on those types of surfaces? This would be like to kind of prevent ankle issues.
Yeah, I think if ankle instability or ankle sprains are a or something that you've dealt with, that is that is the treatment for it. That is, it's a fantastic use of the wobble boards. Is if you have chronic lateral ankle instability, this is basically the treatment that you would get with physical therapy and what your home exercise program would look like.
Okay. Lots of questions on bunions. Let me see if I can find one. So, can you talk about quickly kind of the cause and then maybe how you might treat someone who has bunions?
Yeah, so bunions obviously one of the most common things that kind of come through a foot and ankle surgeon's clinic. And one of the there's a lot of different causes for it. So it's hard to pinpoint an exact cause. One of them is instability at the joint, not at the level of the bunion, but the one just above it. So that typically can contribute. One of them is arthritis at that joint, typically can present like a bunion. Sometimes having a flat foot can be a contributing thing to having a bunion. In terms of treatment for bunions, really the options are limited. The options really are wider shoes, a shoe stretcher, open-toed shoes, which is frankly tough in Michigan for most of the year, or a surgery. And depending on your specific bunion and the severity of it and what it looks like on x-ray, as well as on physical exam, we would be able to kind of tailor your bunion operation to really what your foot looks like. There's anything from minimally invasive bunion surgeries that can be done with small burrs and small poke hole incisions to fusing the big toe if there's significant arthritis. So that's part of the reason why I didn't include that within this talk was it is such a vast topic that we could probably talk about it for a full hour on its own.
So it sounds like if you're suffering from bunions, a good idea to make an appointment and kind of take it case by case.
Absolutely. I mean, I think the starting point for a bunion is the same regardless of the type. I think, wider toe box shoes and open-toed shoes and a shoe stretcher are a great place to start. But once those things have not worked, I definitely think it's worthwhile to make an appointment and come on in.
Okay. How do you determine when it's time for an ankle replacement?
Yeah, it's a great question. So from my perspective, I think one is obviously you have to have pretty significant arthritis, moderate to severe ankle arthritis. Um, and then from my perspective, again, I'm pretty conservative. So for me, you have to have failed doing a brace and the Hoka shoes or anti-inflammatories, some injections that have proved that one, you do get better with an injection, but it's not sufficient. And then we have a good conversation about whether to do an ankle fusion or an ankle replacement. And I think depending on your x-rays and each patient's specific needs and health history, we really make a decision together on how to proceed.
Okay. Have you dealt with gout? This one's specific to arthritic gout in the big toe. And if so, how did you deal with it?
Yeah, it's a good question. So Typically just for gout. If it's just gout, but there isn't severe or significant arthritis in that joint, you can typically treat it with medications. So there's a good medication called indomethacin. It's in the anti-inflammatory category. You can treat it with um, colchicine, which is another good medication that can be initiated either by me or by a primary care doctor. If there is significant arthritis within that joint, then we really have to decide, how bad of arthritis is there. And typically what we can do is either a shoe insert called a Morton's extension, if the arthritis isn't too bad, or if it's pretty severe or end stage arthritis, we typically have to move on to typically a fusion of that first MTP joint or that arthritic joint.
Okay. And do you deal with bone spurs?
Yeah, absolutely. Definitely deal with bone spurs throughout the foot and the ankle.
Okay. Um, and sorry, go back to the ankle replacement. People are asking if they are 80 plus years old, are they still a candidate? And is there a good success rate? And what's the recovery period for someone that's above 80 years old?
Yeah, it's a great question. So you are absolutely still a candidate. It depends more on you and your overall health and your activity level rather than on your specific age. What the recovery typically looks like for me is I typically do about 3 to 4 weeks of no weight on it. And then I let you start to walk on it in a boot for about 3 or 4 weeks after that. And then we get you started in some physical therapy at around the 6 week mark. I will say that my ankle replacements, I think they tend to do quite well. I think the average success rate is very good. I'd say that about 80 to 90% of people are very, very happy they did it and they would do it again. Um, the survivorship of ankle replacements is not quite the same as that of hip and knee replacements. So typically a good, well done ankle replacement is going to last probably about 15, 20, 25 years, as opposed to a really good hip and knee replacement typically lasts closer to 30, 35 years if they're well done and good implants were chosen. So the survivorship is not quite the same as that of hip and knee replacements, but is definitely improving and it's a developing area.
Okay. Is there something, sorry, let me restart. Can you talk about how you might tell a patient to shop for shoes? So do you recommend like a certain brand or do you recommend running shoes versus, a typical tennis shoe? I'm not sure how to exactly say that, but is there something you recommend for people just for a general daily shoe if they aren't having a lot of issues?
Yeah, I think that's a good question. I think shoes are very specific to the person, so it's a little bit tough to generalize. For patients with arthritis or for patients with a flat foot, which are both pretty common etiologies that I treat in my clinic, what I've found is that Hoka's do seem to work quite well, and they're readily available everywhere. There's another shoe brand called Ultras that a lot of patients have actually recommended to me, and after having seen them, I definitely agree. The biggest thing that I've found is shoes that have a rocker bottom to the bottom of it, so the bottom of it looks like that of a rocking chair almost. They tend to offload the ankle and the foot a little bit better and can potentially help a little bit with preventing pain and irritation of existing foot problems.
Okay. Sorry, one second. And I think you've touched on hammer toes, but this person's asking if you do surgery for hammer/claw toes.
Yeah, absolutely. I mean, we typically, depending on the hammer toe or the claw toe, we can sometimes start with non-operative things, and if those have either been done or if it's a rigid deformity that can't be straightened out with non-operative means, and we absolutely do. I do hammer toes and claw toes all the time.
Okay. Um, this person is talking about cramping in the bottom of their foot during the night. Do you have any suggestions for how to prevent that?
Yeah, so that's kind of a tough question, only because there's a lot of different reasons for cramping. And it's kind of a non-specific, a little bit vague of a diagnosis, because there's a lot of different reasons for that to occur. So oftentimes cramping is kind of a manifestation of plantar fasciitis. So it could be something like that. It could be as simple as you're having muscle spasms overnight. And because you're not using your feet. But muscle spasms can be related to a lot of different things like electrolyte abnormalities. So I don't have a great answer for cramping in the bottom of the foot.
Okay. Can you repeat the top shoe you recommended for flat feet? For
So I would say Hokas are really good, and that's what I've recommended to most people. Most people in my family have flat feet, and those are the shoes and the sandals I've recommended to them.
Okay, so that would be HOKA.
Mm-hmm.
Okay. Is there a cause for persistent ganglion cysts in the metatarsals? And what is the best treatment?
Yeah, so I'll say ganglion cysts. It's not causing any harm by having them. Really, treatment options from my perspective are either live with them, or if they're bothersome and irritating, then you take them out. Um, some doctors will recommend aspirating them or pulling the fluid out. The recurrence rate of a ganglion cyst, if you aspirate it, is probably over 95%. So, from my perspective, it's probably not worth doing if the recurrence rate is 95+% and you're introducing a potential risk for infection. So, typically the options really are live with it or have a surgery to excise it.
Okay. And there are several follow-up questions on bone spurs. Can you just talk a little bit more about how you might treat them?
Yeah, so again, it depends a little bit on the location of the bone spur. So typically, bone spurs signify that there's some sort of arthritis. And it depends a little bit on where the bone spurs are and the degree of arthritis that's associated with it. So if it's really just bone spurs and the arthritis isn't too bad, you can typically either pad up the bone spurs, or you can treat it with just simply taking the bone spurs off. But if there's significant arthritis underlying that as well, then what you need to do is treat the underlying arthritis.
Okay. This person says they have their feet feel tight when walking, and she's wondering if it's a foot issue or a shoe issue. Loosening laces has not helped.
Yeah, so it's a little bit tough because tightness in the foot that can occur in any number of places, and it really depends on where you're experiencing that tightness. I will say that typically tightness in the foot is more of an issue. It's either related to swelling in the foot, and then you're having that swelling for some particular reason, or again, it's related to the tight calf muscle.
Okay. I just have a couple more questions if you can hang in there for just a few more minutes,
Yeah.
actually. Okay. This person says, okay, so it was diagnosed with a ruptured tendon 2 years ago, and they've had cortisone shots, which have helped, done PT, and they wear an ankle sleeve when they're active, it looks like. BioFreeze is also helpful after, looks like. And they're at 75. They're hoping to avoid surgery. So are they doing all the right things, or do you have more recommendations for them?
Allison, can you say that one more time?
Yeah, sorry, it was a lot of detail. Okay.
No, you're good.
So they ruptured a tendon 2 years ago in their ankle. They've had cortisone shots, PT, wear an ankle sleeve when active, and use BioFreeze and ice as well. Is there anything else they could be doing?
Yeah, I mean, I think if those things are working, I would say that keep doing them. I mean, that if that's doing a sufficient job of taking care of your pain, I think that's perfectly fine. In general, what you can do for a ruptured tendon or ligament is you can usually do physical therapy or strengthening to recruit adjacent tendons to be able to substitute in for that ruptured tendon. And that can work actually quite well. So that would probably be the only other thing that I would probably add to that. But it sounds like you're doing everything right, especially if it is working and it's providing the sufficient pain relief.
Okay. And do you have thoughts on foot massage or reflexology?
I honestly probably don't know enough about it to give an educated opinion. I would say that the literature does not, in general, support its use. But it's not because it's against it, but because there isn't enough literature written on the subject.
Okay. Any suggestions for how to treat arthritis in the big toe?
Yeah, so arthritis in the big toe can be treated with any number of things. So it can be treated initially with something called a Morton's extension orthotic. It's basically like a carbon fiber insert that goes into your shoe. And what it does, it creates a hard, stable surface on the insole of your shoe, and it prevents excess motion at that big toe. And when it does that, it by limiting the motion in an arthritic joint, you thereby decrease the pain. So that's really where we start. You can do anti-inflammatories. You can do shoe changes. The Hokas work quite well for that as well. And then the next option, depending on the degree of arthritis, you can decide whether you want to do a surgery called a chylectomy, where you just take off the bone spurs, or do you do something called a first MTP fusion, where you eliminate the motion in that joint, but that also eliminates the pain. And I will say that most patients with a first MTP fusion, outside of a few activities, cross-country skiing, mountain climbing, rock climbing, everybody else seems to do quite well with a first MTP fusion.
Okay. And then can you talk about, are there some common causes for pain on the top of the foot?
Yeah, so on the top of the foot, especially in the middle of the top of the foot in the middle, kind of the midfoot area, the typical causes, depending on your age, are arthritis. Midfoot arthritis is a very common entity. And then a stress fracture. So depending on your pain and how it's presented and where the location of it, we'd be able to kind of hone in on that a little bit better in clinic with an X-ray or an MRI. If it is arthritis, we can always proceed down the path of treating arthritis with injections, or potentially a fusion surgery, but we probably have to figure out exactly what's causing it first. But typically a stress fracture or midfoot arthritis are the main sources.
Okay. And do you think there's a benefit to walking in the sand if you have a damaged Achilles tendon?
I don't think that there's a benefit to it per se. I think walking through the sand, it certainly requires more force across your ankle, and it's an uneven surface, so you're definitely going to activate your muscles more. It's more likely to cause irritation of the Achilles tendon, but if it doesn't seem to irritate it, I'd say go for it.
Okay. And if you recommend orthotics for a patient, is that something that happens within your practice, or how does that work?
Yeah, so typically, 95% of people that come through my clinic, I typically recommend an over-the-counter orthotic. That's really where we start. The other 5 or 10% of people, it's because their foot deformity is severe enough where I don't think that an over-the-counter orthotic is really going to cut it for them. And so in that case, I'll utilize custom orthotics. But for that custom orthotics, we typically send patients to a different location to be able to get their orthotics fit and made for them. But 95% of people typically leave with the Amazon link to one of the orthotics that I'd recommend.
Okay, and again, I will share that in the email that you will receive after this in the next couple of days. Okay, and then I'll just ask one or two more questions here. So, how about running? Is that bad for ankles?
Yeah, it's a good question. Running is a high impact activity. So in general, running is much tougher on your joints than swimming, an elliptical or a bike is. So anything where your foot is leaving the ground and impacting it hard, it's going to have a damaging effect to your joints. And so, in terms of low impact activities, like I said, elliptical, biking, swimming, anything where your foot really isn't leaving the ground, it just stays on a consistent, stable surface is going to be better for your joints than running would be. But you also have to live your life. And if running is something that you want to do, the problems that can result from it can be treated. So, I definitely see both sides of it. But really, any high impact activity, which includes running, sports, cutting and pivoting activities, CrossFit, things like that, are probably having some detrimental effect on your joints.
And walking, would that be counted as a high impact as well if you're sort of speed walking, or is that a little easier on your ankles?
So that's much easier on your ankles and
Okay.
your feet. So I really wouldn't count that as in the same category. It's really when your body's leaving the ground and hitting the ground at a kind of a higher impact or a higher force that's generated. That's really when it's more of a problem.
Okay, one last question. So if you find yourself with a foot or ankle injury and you're in need of sort of immediate care, is your recommendation to first go to urgent care or an emergency department? And
Um, can you ask that question one more time?
so if you find yourself with a kind of an acute injury, is your recommendation to go to urgent care to get those initial x-rays or emergency department, I guess, depending, um, to get those initial x-rays and then the referral to an orthopedic surgeon?
Yeah, so I think it's a great question. In my experience, what I would do is if it's an injury where you can put weight on it, if there's swelling and bruising, but you're like, I can put some weight on it, I would probably call instead of going to an urgent care even, I would call my clinic or call our department, and typically we can get patients in my clinic. I can get patients in within a few days, especially for a more urgent request. So in general, what I've found is that an urgent care can probably be skipped over, and we can typically get patients in relatively quickly within a day or two.
Okay.
If it's a more severe problem where you're unable to put weight on it, I would recommend probably going to either the urgent care or the ER setting. Depending on you and basically your health problems and your ability to get to either an urgent care or an ER, that would help with kind of making the decision of how to go. Obviously, if it's an open fracture or a really severe injury, an ER is going to be more appropriate. If it's something where you have easy transportation and somebody can help you get to an urgent care, it's certainly going to make your life a whole lot easier.
Okay. And the nice thing about you, Dr. Bakshi, is that you sort of see patients in two areas, which is the Livonia area and the Brighton area. So hopefully between those two kind of large circles, one of those practices would be closer for everybody. There is one more question, sorry. She said this woman is asking if we can suggest a good walking shoe. Would that fall to the Hokas again?
Yeah, I think Hokas are great. I think New Balance makes a pretty good regular walking shoe. I have some on running shoes that I like as well. So I think for walking in general, it's really whatever's going to be comfortable for you. But I have found that the Hokas are very good as well.
Okay. And again, you're looking for like that rocking sole, right?
Yeah, I've been a big fan of that, and my patients in clinic have definitely raved about it back to me, and so it's definitely kind of confirmed to me that that's one of the best shoes on the market.
Okay. And you can go to like a running specialty store or some of those more specialty stores where the salespeople could probably help direct you as well. Do you think that's a fair statement?
Yeah, absolutely. I think depending on the shape of your foot and what you're looking for in your shoe, some shoes are far better for durability, while others are far better for if you're trying to get a 5-minute mile. So I think it really depends on what you're trying to achieve.
Okay, awesome. Well, I don't know that we got to every single question, but hopefully we touched on most of the popular topics. This entire discussion was a very popular topic. So thank you so much for taking the time to present and answer so many questions and staying on a little bit late for us. We really appreciate it.
No problem. Thank you all for joining. And if you need me, my contact info is on the first slide, and I think Allison will also probably send that information out as well. So I'm happy to see any of
Absolutely.
you in clinic in the future.